last year at Midway, Utah, I was stuck in the exact same position of following Mickey. I said to myself, note to self, don't let that happen again. What an idiot I am. So, note to self, next year, don't follow Mickey. So, I'm actually up here just to be a facilitator, not something I'm very good at. So in this case, what we're going to do is we have essentially a panel of clinicians who are actually doing all the work. They're carrying all of the weight, and I just talk. So Alan is going to talk about the natural history study. Alan and Tim are going to talk about the status of the natural history study. And then I'm going to take do a quick slideshow on where IRSF's research approach is going, just to update you. And then Walter, Jeff, Sasha, and Dr. Naidu are going to talk about their clinical trials. So strap on, get in a seat, tighten down the belt. Alan, you're up.
This is really a fast run through the various epochs of the natural history study. And it'll be pretty quick if we can get the slides up. But I wanted to start out by talking about really the most important element in this, and that is the research team. We have investigators at Baylor, at Greenwood Genetics Center, at UAB, and in Boston Children's. And of course, we have physicians there, but we couldn't do the work without the other people in the staff or the other support. And I think they hold us up, we don't hold them up. They're the ones that are doing the heavy lifting, but perhaps we get most of the credit. So if we get the slide, you'll see who those people are. We have been funded continuously now since 2003 by the National Institutes of Child Health and Human Development. It was an initiative that was started with the Office of Rare Disease Research, which was initially in the office of the NIH director. It's now part of a center called NCATS, National Center for Accelerating Translational Research. We couldn't obviously do this without the funding. It has been relatively expensive, but the amount of money we have to divide among the centers, and we're not looking just at Rett syndrome, but also at Angelman syndrome and Prader-Willi. So when you divide $1.25 million and you take out the indirect cost, because the institutions like a lot of money, they take away, and then you divide that by 3 with the individual studies. So this is one of the friends that you might have seen earlier, and this is the team. And you can see the individuals here, and Jane Lane, who's my right-hand person, probably my left hand too, is just made sure the slides were working. But we couldn't do this, obviously, without the many families and their daughters who have participated in the study, and some sons who have participated in this natural history study. It is a regular meeting. If you are now less than 6 years of age, we see you twice a year, and if you're more than 6, we see you annually. So that's a big deal for people to come back, and we understand that things get in the way, and things have occasionally gotten in the way. So the natural history study, we had the first phase was to enroll 1,000 girls with Rett syndrome or with mutations in MECP2. The goals were to understand the phenotype-genotype relationships. We had principal sites at Baylor, Greenwood Genetics Center, and UAB. This was round 1. At that time, it was the International Rett Syndrome Association that actually at least came up with part of the idea of travel clinics, because you can see we were all in the South. We weren't covering the country very well. And how do we do that? We organized travel clinics in Oakland, Chicago at the Rush Medical Center, in New Brunswick, New Jersey at Rutgers, and in Florida. And we actually, because Florida's a fairly long state, we went to 2 different places. And why we did it, we picked Miami in the summer and Tampa in the winter, and that was probably not the right idea, but we did it. And so then we were very successful, and we moved on to phase 2. We were still planning to enroll 1,000 girls or women. We organized increasing the goal because we reached 1,000. We're now up to 1,350. We have a database, and we had to have a high enough number in the database to allow us to enter patients beyond 1,000. And now we added the Boston Children's Hospital as part of that. At this point, in between, the RettSyndrome.org, previously IRSF, became part of our support network, and they really have funded the travel clinics. We didn't have enough funds in the grant to fund the travel clinics. Currently, we have 1,191 participants. 927 have classic Rett, 166, I believe, have atypical Rett syndrome. 98 have Rett syndrome, have MECP2 mutations, but do not have features of Rett syndrome. Those are equally divided essentially between girls and boys. And in some of the cases, we have boys with MECP2 duplication, which is not a mutation in the gene, but is an extra copy. And that's a long story, but basically, extra copy of the gene is just about as bad as not enough copies. We also have some mothers of these boys who also have the mutation, but because of probably favorable skewing and X activation, they do not express the features of any particular disorder, except they probably have a higher incidence of obsessive-compulsive behavior and perhaps depression. So the lessons we've learned. More than 95% of girls in Rett syndrome have a MECP2 mutation. 8 common point mutations make up about 60%. 15 to 18% of the girls have deletions or insertions, and the remainder of the 300 or 250 unique mutations in Rett syndrome are made up by a small number or perhaps a little bit larger number, but they don't come up to these numbers of the 8 common point mutations or the deletions. We recognize that the incidence of the disorder through studies done in really in Australia is about 1 in 10,000 births. That the familial Rett syndrome is very, very uncommon, less than 1% probably. That variant Rett syndrome represents about 15% of our total, and that girls with variant Rett syndrome, about 75% of them have mutations. We've learned a whole lot more, and we could talk for quite a long time about that. I just wanted to show one slide, and this has a distribution of the 8 common point mutations and some of the more common other mutations, and to show that there is a range of clinical severity with some of the milder so-called mutations having a better clinical features than some of the other mutations. But there are really, you can see that at the 2 tails, they come together pretty closely. And actually, 2 girls with the same mutation may look very, very different. Those are due to other features that we are planning to look at in the next round. We have a number of publications to date, and I won't review all of these. I did want to point out that the regression period, which is really critical in our minds for making the diagnosis of Rett syndrome, and most of the regression begins at 12 months to 30 months of age. And the remainder, small percentages are on either side of it, but we understand that that is a reason for a delay in diagnosis. And the classic Rett syndrome, the age of diagnosis is at age 3. In the atypical, it's age 4. But by the time they get to our natural history study, the average age of enrollment, you can see, is closer to 9 or 10 for these different disorders. The median age actually is probably a more accurate reflection because we have a long tail out in older age groups which really skew the average. So the median age actually is closer to 6 or 7. And finally, who's making the diagnosis? And this is one of the critical measures that we need to look at. Neurologists about 1/3 of the time, developmental pediatricians about 1/3, geneticists about 25% of the time, and pediatricians about 5% of the time. And we think, and we need to get the message out to pediatricians and help them make the diagnosis earlier, because we fundamentally believe that the earlier we make the diagnosis, the earlier we can initiate the therapies that are coming forward. Our future goals are to improve the diagnosis, actually, to expand the biobank by doing X chromosome and activation studies, whole exome sequencing, and a number of other studies. We also are going to look at other related disorders such as CDKL5, FOXG1, and MECP2 duplication disorder. And Tim is going to talk about the CDKL5 at least. And we're going to try to work more with international sites to create databases that are translatable and transferable across the international borders so that we can work together, because these clinical trials do take a large number of individuals, probably more than we have even in this country. So we need to be able to work internationally about this. It'll bring up a whole host of regulatory issues, but it's something that we'll have to face. What is the importance of IRSF? They have a continued role in recruitment and promotion of research. They are the linchpin that gets participants into our studies. They're important for supporting clinical training. We need to see young people coming along. I'm a little bit old. We want to promote information exchange among everybody. This is an open network. We do not restrict information. And we want to continue annual opportunities to meet with all of you so that we can keep a close conversation with you. And I want to close again by reminding us that we wouldn't be here without this gentleman and this gentleman. So, thank you.
So, thank you. My name is Tim Benke. I am the medical director for the Rett Clinic at Children's Hospital Colorado, University of Colorado School of Medicine. So, I don't have slides, so it's pretty straightforward. But I want to talk to you about what we want to do with looking at Rett-related disorders as part of the Natural History Study grant. Where we live, I think, is reflective of how this group is approached this. Our Rett clinic is a Rett, it's always been a Rett and Rett-related disorders clinic. And we've been inclusive in that way, and I think it's been very helpful, as I think it has been for this group. What we are trying to do is, as the other clinics, is to provide a framework so that we can answer a lot of the questions that we have with regards to our patients and families. And so I have a couple of thanks. I want to thank, first of all of you. It has been an absolute trip and joy to take care of your sons and daughters. And I want to thank this group for including me in this next round of the natural history study. So Rett-related disorders include CDKL5 and FOXG1. And with my partners is this part of the grant, which were Alex Paszczykowski at University of Rochester and Eric Marsh at Children's Hospital Philadelphia, but also with a lot of input from the whole team here, we came together with this section of the grant to look at those Rett-related disorders. And essentially what we want to do is to utilize the expertise that's been brought over the years with studying MECP2 disorders to CDKL5 disorders. So what are our questions? What do we want to approach? And we want to know, what is the natural history of the disorder? How can we use this information to better counsel you? What are the things that we should be looking at, not looking at? What's important? What isn't important? And then the next big piece is we want to develop quantitative biomarkers so that we can understand more about the disorder, and again, how we can make better predictions. So we all have our fingers crossed and are hoping that the grant gets funded. But all is not lost. If it doesn't, there's always hope. And there have been a number of discussions and talks of how we're going to move forward. And this has been a really big part for us, is that our clinic has been made an International Foundation for CDKL5 Research Center of Excellence, which really pushed this whole thing going. And I don't think that we could have done it without that. Because what we were able to do is to start to developing, what would our questionnaires, what would our tools, what would our instruments look like as we went forward with a natural history study. And so with Walter and Jeff and Daniel Tarquinio and Helen Leonard and Jenny Downs, we've been talking a lot to try to figure out what this sort of thing would look like. And so it's been nice to work together and to be part of that big team for doing that. So, thanks.
While they're getting the slide set, I think that actually Mickey touched on a point that I want to touch on. And if you remember in New Orleans when Larry Glass said, "I'm in," and Nurin announced yesterday that their inclusion enrollment actually closed, I should have also mentioned that the IGF-1 trials enrollment has also closed. And that means that both of those clinical trials are essentially now on their final lap. They're both essentially completing their girls and studying, and when the last girl in each of those studies is done, they'll lock down the data and start their analysis. So we have two reasons to celebrate, not only the NNZ 2566 enrollment closure, but also the IGF-1 enrollment and closure. And, oh, there I am. Paige made me put this picture on there to remind me of who I am when I get started. I oftentimes forget. So last year I talked about sort of my view of your world, and what I actually talked about was, in your world you see developmental delays, you're heading off to the pediatricians and to your clinicians to get a clinical evaluation, hopefully a diagnosis, so that they can come up with a treatment, and then you're back in the game again. So that was your world as your child was developing, and part of the challenge was when, in fact, things happened, it wasn't a nice, smooth trip. We sort of got stalled somewhere down in here. So when we sort of look at this sort of layout of this natural life cycle, one of the things that's striking is that now that we know more about Rett, we all sort of say, can we slow this down? What can we do to slow this down? And we have to constantly ask ourselves that question. And as Alan had said, if the pediatricians are making earlier diagnosis, maybe we can do things that actually slow things down. We don't know that, but let's actually really push in that direction. The other thing, the question that many of us still should be asking is, do we have the best assessment tools? Are those genetic? Are they clinical? Let's continue to work on our assessment tools. And what are the treatments, and what are they designed to do? So, and will they actually help my child? And finally, when you think about this, is there a physical therapy or occupational therapy or cognitive therapy designed that will actually help with any of loss of function in my child? So we need to be helping you with all of that, and I need to be pushing the research in regard to all of that. So where is the research? So we still haven't done much research in this quadrant, and we need to do more in that quadrant, and that is to understand how to slow it down, how to make an earlier diagnosis. Right now, it's a clinical diagnosis made by the panel to my left and to all of the physicians out there. But is there a faster, quicker, better way to do it? We're working on that. And again, as I stated last year, this is where a lot of the research has actually been since Huda made the initial finding about the association of MECP2 with the gene, and that is trying to essentially understand the functions of this bad boy. And as we move forward and we understand more and more, we're trying to essentially figure out how to work around it. If we can't fix it, how do we work around it? And that's part of what we're trying to do as we move forward. And the thing that many of us are always thinking about is how do we essentially move more treatments into this quadrant? And if we can move more treatments into that quadrant, how will it essentially change Rett biology? And then how do we actually look at the physical therapies, occupational therapies, cognitive therapies, and other fields, and can we incorporate that into our field to essentially help our girls? So, can we do better? Absolutely. So, are there anecdotal stories out there that we can actually take from to essentially try to look at what's happening in this quadrant to essentially help with delaying any of the problems? Can we use the discovery-based science that sits in that quadrant of assessment to essentially take those discovery ideas and move them into medicines quicker, faster, better? And if we move them into that quadrant, can we build aggressive programs, as you just heard Alan state, and I think you'll hear both Walter and Jeff state this as well. We need essentially a very aggressive, well-thought-out clinical research program because of the numbers that we're going to need to actually do those and to test the medicines as we try to test them for efficacy. And finally, what can we learn from other fields of rehabilitation? Yesterday, Pam Diner put together, and many of you are going to go to her session tomorrow, but we heard of presentations from spinal cord injury fields and from other fields using virtual reality, and how can we adapt those and move them into our environment to actually help our physicians possibly come up with better outcome measures. So we are charging forward in that regard, and hopefully we'll be able to essentially report more on that next year with the start of our new program in neurohabilitation. So what's missing? So earlier diagnosis, we're on it. We're going to move on it. Can we move more of these ideas to medicine? Yes, that's part of what we're trying to do. That's part of the ideas behind the Scout initiative that we have. Take the great discovery-based ideas, move them through very, very controlled, blinded, randomized preclinical trials to see if, in fact, those medicines are things that can move forward. If they are available, can we then essentially move them and test them in a clinical environment with the folks that you see on the stage? And finally, can we adopt and bring in more cognitive, physical, and speech therapy programs that are used in other fields and adopt them and adapt them to Rett syndrome? Now, so where are we going right now? So the history of IRSF's research program has been one of basic discovery. This is where we have been working hard along with the National Institutes of Health and other foundations to essentially try to assess what the function of MECP2 is, where is it expressed, what's the biochemistry behind it, is there genetic reversal, is genetic reversal possible, are biochemical reversals possible? And at the same time, as you just heard Alan articulate the power of the natural history study, IRSF bought into and became a practicing partner with the natural history study very early, and from the standpoint of looking at the numbers of people affected, identifying variants, the standards of care, earlier diagnosis, better outcome measures, and patient registries. Those are incredibly important as we move forward. And I can't say enough to the team of faculty around the country who have participated in a natural history study, because that's what they're going to give us, all of this, which is absolutely needed as we move forward. So the basic discoveries that we've had, my view and the saying that I've coined at IRSF, rettsyndrome.org, is all of those basic discoveries are there, and what we're trying to do is correct the biology with them. But at the same time, introducing a new program that looks at neurohabilitation, understands essentially the idea of bringing new and innovative types of physical, occupational, and speech therapy and cognitive therapy together, so that as we try to correct the biology, the other side of the coin is resetting the neurology. Our girls have missed some neurologic development. If this panel of physicians can correct some of the biology with pharmacologic intervention, we then have to sit and say, how do we reset the neurology? How do we retake some of that cortical real estate and make it work for us in the way that we want it to work for us? And that's what the neurohabilitation program is. And I think if you attend Pam Diner's talks tomorrow, she'll be articulating how some of the sensory input physical therapy that they're doing will actually do that. So all of that together is essentially designed really to essentially screen compounds, look at how those compounds identify which compounds are the best to be tested, and what kind of physical therapies and occupational therapies can really reset the neurology. All of that really to do the thing that you all want to talk about and want to hear about, and what Mickey talked about is more clinical trials. And those clinical trials are designed to enhance synaptic networks. How do we then fire and wire those new networks? And how do those therapies, both physical therapy, occupational therapy, and cognitive therapy, help us gain function? So the thing that these are the opportunities that I think are missing, and we're going to, IRSF is going to push on these. You've heard me speak, cognitive therapy, physical therapy, occupational therapy. How do we bring those into the fold with our clinicians and our basic scientists? How do we identify additional therapeutic compounds? One of the initiatives that would be nice is essentially dovetailing with the brain initiative out of the NIH. How do we do better imaging? Then start looking at combined therapies, earlier diagnosis, and essentially growing clinical networks so we can do this in more places, quicker, faster, better. Now, you all know me and Janice. That's our contact information. Now, one of the things that was very interesting about our keynote speaker on Tuesday evening, his name is Mike Marisanek, and he is essentially one of the fellows who's pushing cognitive therapy quite hard. 2 years ago, you all know the Larry Glass story. Tuesday night, Mike Marisanek said the same thing. I will help anybody I'm in. Let's get started. Let's do this, and let's chase down Rett from a cognitive therapy standpoint. So this is one of the leading programs in the country called POSIT. You can go on the website and look at it. It's essentially cognitive therapy for all of us to stop your brain aging, and he wants to bring it in to our house and help us with Rett for remapping cortical real estate. So it's very exciting. It's 2 years since Larry announced his involvement, and Tuesday night, Mike announced his involvement. So that was very exciting. Now, I'm going to be around today and tomorrow and happy to take any questions that you have. Stop me in the hall, pin me up against the wall. I'm happy to answer any questions. Now, the most exciting part of this morning's is going to be hearing from the clinicians. We're going to hear about 4 clinical trials that are going on, and they're all great stories. And so, without further ado, Walter, you're up to bat.